Okay, for my case study, the herniated nucleus pulposus, or the HNP. The patient's profile, her name is Precious de la Cruz. She is 39 years old, female, and she is married. Her occupation is a physical therapist, which, as a physical therapist, you have to lift and move people's bodies or mobility a lot. Her complaint is a sharp shooting pain radiating from the lower back to the right calf, accompanied by a persistent tingling sensation in the toes. Now, history of present illness. It says that 2 weeks ago, the patient experienced a sudden twinge in her lumbar spine after a prolonged period of driving a long-distance delivery route. What began as a mild nagging stiffness in the lower back was initially managed with warm compress and ibuprofen with temporary relief. However, within the past 4 days, the discomfort has progressed into a sharp, lacerating pain that originates from the lower back, tracked to the lateral aspect of the left thigh, reaching the ankle. The patient described the sensation as a burning or a searing sensation, currently rated as a 7 out of 10 on the pain scale. The symptoms are acutely exacerbated by transition from sitting to standing or by performing straight leg raise. Also, she notes pins and needle sensation or paresthesia on the top of her left foot and noticeably weakness when trying to push off with his toes while walking. He denies any saddle anesthesia or changes in bowel and bladder function. So the patient's past medical history is Ms. De La Cruz reported experiencing a strained back 2 years ago following a minor car accident, for which she went to physical therapy for 4 weeks. Now, she was diagnosed with degenerative disc disease or DDD at the age of 39. She has no prior hospitalization related to spinal conditions aside from a cesarean section performed 10 years ago. The patient has no known drug allergies. She is a former smoker who quit 5 years ago with a previous history of smoking one pack per day for about 10 years. Her BMI is 29.5, placing her in the overweight category, which may contribute to increased mechanical stress on the spine. For family history, Ms. De La Cruz father has a history of chronic lower back pain and underwent a laminectomy in his 50s. Her mother has been diagnosed with osteoarthritis and type 2 diabetes mellitus, indicating a possible familial predisposition to musculoskeletal and metabolic conditions. Now, what is HNP? With herniated nucleus pulposus is a condition in which of the part of the soft gelatinous central portion of the intervertebral disc protrudes through a weakened or torn area of the disc, herniated. Now, this can result in compression or irritation of nearby spinal nerves, leading to symptoms such as localized back pain, radiating pain, numbness, tingling, or muscle weakness. This condition is commonly referred to as a herniated disc. For the pathophysiology, herniated nucleus pulposus can result from various factors such as injury, repetitive strain, and smoking. Injury occurs when suddenly heavy lifting is performed using the back muscles instead of the legs, as per carrying patients all day. Repetitive stress like continuous twisting or pulling, and smoking, which impairs nutrient delivery to the disc and speeds up degeneration, can also trigger this condition. All these factors may damage the intervertebral disc, leading to the formation of cracks in the annulus fibrosus that weakens the disc resistance to reherniation of the nucleus pulposus. This damage results in a decrease in proteoglycans and water content within the disc, making the nucleus more prone to protrusion or rupture. Now, such protrusion or rupture can cause radiculopathy, commonly known as a sciatica, characterized by sharp shooting pain radiating down the buttocks to the leg, typically on one side. The compressed nerve may also cause paresthesia, as the patient said, and such as numbness or pins and needles. Motor weakness may also be occur, presenting as difficulty lifting the foot or weakness in knee or ankle. The body may respond by including muscle spasms to protect the injured area. If left untreated, the herniated disc can severely compress nerve roots on the lower end of the spinal cord, leading to cauda equina syndrome, a serious condition involving compression of the nerve roots known as the cauda equina. Symptoms like saddle anesthesia and new onset of bowel or bladder inconsistency require immediate medical attention. Preventing nerve compression from progressing into chronic pain involves managing mechanical pressure, reducing inflammation, and preventing nervous system sensitization through NSAIDs. This nursing role aims to halt development of chronic pain syndrome. In cases of herniated nucleus pulposus, the extruded disc material can significantly compress or cut off blood supply to the nerve roots or spinal cord, potentially causing permanent nerve damage if not addressed. Nursing action includes conducting frequent neurovascular assessments, checking sensation, movement, and pulses in the lower extremity. If the herniation is untreated, it may further compress the spinal nerve, impairing signal transmission to muscles, leading to muscle atrophy and reduced strength. To prevent this, nurses should coordinate with physical therapy to provide back-school education or core strengthening exercises aiming to prevent muscle wasting and promote recovery. For the diagnostic tests, the imaging here tests that are used is imaging test and spinal x-ray. This is often the first diagnostic step to evaluate vertebral alignment and structural integrity. While it does not show soft tissue herniation, it reveals secondary signs such as a narrow disc spaces or vertebral instability, and helps rule out other conditions like fractures or spondylolisthesis. Nursing care includes verifying pregnancy status to prevent radiation exposure, removing metallic objects to avoid artifacts, and instructing the patient to stay put during the procedure. Post-procedure care involving helping the patient find a comfortable position to reduce any discomfort caused by the imaging process. Magnetic resonance imaging, or MRI, considered as the gold standard for diagnosing HNP. This provides detailed images of the intervertebral disc, the spinal cord, and nerve roots, enabling precise identification of nerve impingement. Nursing managers focus on safety screening for any metallic implants that could be affected by the magnetic field. Preparation may include coordinating sedation for claustrophobia or administering pain relief for discomfort during the scan. Afterward, the nurse monitors for changes like orthostatic hypotension and offer emotional support regarding the results. For the CT scan, this produces detailed cross-sectional images of the bony spine and are especially useful in patients with prior spinal surgery or degenerative disc diseases. Nursing responsibilities include ensuring the patient wears loose clothing, remains still during the scan, and monitoring for adverse reaction if contrast dye is used. For myelogram, when standard imaging is inconclusive, a myelogram involves injecting contrast dye into the spinal fluid to visualize the spinal cord and nerve roots. For pre-procedure care, this includes encouraging high fluid intake for hydration, withholding food and drinks for 6 hours beforehand, and assessing for allergies to lidocaine or iodine. And for post-op, of course, the nurse monitors for complications like cerebrospinal fluid leaks or meningitis, and instruct the patient to report immediately for any severe headache, neck stiffness, fever, or inability to do so. For the nerve function test, there is two: the nerve conductive study and the electromyogram. The NCS is the test to measure how quickly and effectively electrical impulses travel along the peripheral nerves. For EMG naman, it evaluates muscle electricity activity to determine if symptoms like radiating pain and weakness are due to nerve root compression or muscle disease. To conclude, to summary lahat na lang, the nursing responsibilities include preparing the patient for sensations such as a mild electric shock or needle insertion. Pre-test care involves instructing the patient to avoid applying skin creams for 24 hours to ensure proper electrode contact, and screening for contraindications like pacemaker or blood thinners. During the procedure, the nurse must keep the patient warm as cold temperatures can affect results. Afterwards, care involving removing electrode paste, monitor for hematomas, and informing the patient that they may resume normal activities and medications, including muscle relaxants or cholinergics, which may have been temporarily withheld. For the nursing care plan NCP, I have 5 here. Number 1 is first is acute pain. The nursing diagnosis for this is acute pain related to nerve compression caused by herniated nucleus. The goals for this one is within 24 to 48 hours of nursing care and medical treatment, the client will report decreased pain and display improved comfort. For the 2 of the nursing interventions here, of course, assess pain details location, including the intensity and radiation pattern. These position the client in semi-fowlers with knees slightly flexed or side-lying with a pillow between the knees, administer precise analgesics, NSAIDs, or muscle relaxants as ordered, and teach non-drug pain relief methods like deep breathing, guided imagery, or cold and heat therapy. For evaluation within 24 to 48 hours, the client reports pain reduction from 8 to 10 to at least 3 to 10 and can rest comfortably without facial grimacing. For the problem number 2, impaired physical mobility. Impaired physical mobility related to neuromuscular impairment and pain. For the goals and outcomes, in 2 to 4 days, the client will maintain or improve strength and functional ability of the affected limb. Now, schedule activities with rest periods, encourage participation in ADLs within limits, assist with passive and active range of motion and core strengthening exercises, support with activity progression, and teach proper body mechanics. Evaluation is in 2 to 4 days. The client demonstrates improved strength and function through active ROM exercises. Number 3 is sensory perceptual alteration, which is basically disturbed sensory perception related to nerve root compression. Now, goals is within 2 to 4 days, the client will show improved sensory awareness and verbalized understanding of injury prevention strategies. For nursing interventions, regularly assess sensory function, of course, every 48 hours. Instruct the client to inspect the skin daily for any redness, blistering, or sores. Ensure a safe environment, clean floors, and proper footwear to minimize any injury. And then test water temperature with an unaffected part of the body before bathing or applying heat. Evaluation is in 2 to 4 days. The client accurately identifies light touch in the right foot and can verbalize 2 safety precautions to prevent injury. For problem number 4, activity intolerance. Activity intolerance related to pain and decreased physical endurance. For the goals, nursing intervention, assess level of fatigue in response to activity, encourage gradual increase in activity as tolerated, and schedule activities with rest periods, assist with ADLs as needed, and monitor vital signs before and after activity. Goals and evaluation. Within 2 to 3 days, patient demonstrates improved activity tolerance and perform ADLs with less fatigue as reported by patient by able to walk without losing their breath. Now, disturbed sleep pattern for problem 5. Nursing diagnosis is disturbed sleep pattern related to discomfort and surgical pain. Now, goals and outcomes is within 2 to 3 days, the patient will report improved sleep quality and achieve at least 6 to 8 hours of rest. For the nursing intervention, of course, assess sleep patterns and factors affecting the sleep, encourage comfortable positions before sleep, and administer prescribed analgesics before bedtime, and of course, promote a quiet and comfortable environment for the patient, and teach relaxation techniques such as deep breathing and guided imagery. For evaluation, within 2 to 3 days, patient reports improved sleep and decreased nighttime awakenings. To move on to the medical management, the treatment for HNP is primarily conservative, aiming to decrease local inflammation and relieve pressure on the nerve roots to promote natural healing. The core approaches includes a short period of rest within 1 to 2 days combined with significant activity modification. Patients are advised to avoid activities that put strain on the spine, such as heavy lifting, twisting, and are guided through a gradual supervised resumption of movement. Medical management involves multiple approaches to address different aspects of pain. Non-steroidal NSAIDs like ibuprofen or laxaprofen are prescribed to reduce inflammation both systematically and locally. Muscle relaxants are used to break the cycle of muscle spasms and guarding. For sharp radiating nerve pain described as electrical in nature, neuropathic agents such as gabapentin and pregabalin are essential. In cases of severe or acute radiculopathy or short-term oral steroids like targeted epidural steroid injections may be administered to deliver concentrated anti-inflammatory effects directly to the epidural space. Additionally, multidisciplinary care includes physical therapy focused on improving posture and strengthening the core muscles to stabilize the spine and reduce pressure on the disc. Nurses play a key role in coordinating these therapies and providing non-pharmacological pain relief options such as heat or cold therapy, traction, electrical nerve stimulation units to help alleviate these symptoms. For the surgical management, surgical treatment for HNP is reserved for a small subset of patients, typically when conservative therapies have not relieved any symptoms, for about 6 weeks. Surgery is prioritized if the patient experiences severe, poorly controlled pain, worsening numbness or weakness, significantly difficult standing or walking, or a loss of bladder or bowel control. The most common procedure is called a microdiscectomy, which involves using a microscope and a small incision to remove only the herniated disc fragment. Nursing responsibilities for this procedure includes the frequent hourly neurological assessments, of course, or what we call here neurochecks, to evaluate motor functions such as dorsal and plantar flexion, and sensory perception in the lower limbs. This helps confirm successful decompression and enables early detection of postoperative hematomas. To preserve spinal alignment, the nurse assists the patient in log rolling, or a single unit when moving in bed, strictly adhering to a no-twist rule to prevent stress on the surgical site or the re-herniation. The nurse inspects dressing for clear drainage, known as the halo sign, which may indicate a cerebrospinal fluid leak or a CSF leak, and monitors for headaches related to position or hydrostatic hypotension. Pain management involves distinguishing between normal incisional pain and the return of radicular leg pain. Early ambulation, usually within hours after surgery, is encouraged to prevent complications from immobility, while enforcing restrictions such as the BLT, no bending, no lifting, and generally for more than 5 pounds, or of course no twisting. For patient undergoing an endoscopic disectomy, a minimal invasive outpatient procedure, nursing care primarily involves frequent neuro assessments of the affected leg and monitor vital signs to confirm the patient's ability to urinate independently before discharge. The nurse also inspects the puncture site of hematomas or CSF leaks and educates the patient from the tingling sensation that may reoccur as the local anesthesia wears off. A laminectomy involves removing a part of the vertebral lamina to create space, requiring the nurse to administer muscle relaxants for postoperative spasms and monitor Jackson-Pratt or JP drains for excessive drainage. When spinal stability is compromised, a spinal fusion may be performed, and the nurse must monitor the donor site, such as the iliac crest, for signs of infection and assist with applying a back brace like a TLSO before ambulation. In cases of artificial disc replacement, which involves an abdominal approach, the nurse focuses include monitoring bowel sounds, checking for abdominal distension, and encouraging the patient of passage of flatus to assess gastrointestinal function. Frequent neurovascular checks include pulse assessments and skin temperature evaluation. The patient is advised to avoid hyperextension of the spine during initial recovery, and across all procedures, the nursing priorities include safeguarding neurological function, maintaining spinal stability through proper body mechanics, and preventing post-operative complications by vigilant site assessments and thorough patient education. If you want to see the references, it's in the last page of the Canva. Thank you.